Please, Dan.
Okay, thank you very much. So after Lorenzo and Laurent teed me up, I'm going to talk about how we can actually use this at the bedside to set PEEP. So I start with a patient. This is a 46-year-old man who came to our ICU several years ago, massive trauma, compromise of the circulation to the legs, had a huge fluid resuscitation, so had essentially anasarca, a tense abdominal wall that had been packed. And we found this patient in the morning on controlled mechanical ventilation, a tidal volume of 535 cc's, an FiO2 of 1, and a PEEP of 13. So we asked ourselves, what can we do for this patient? Now, the strongest evidence for ventilator support in ARDS is, of course, from this trial. Low tidal volume saves lives, and the difference, the dark blue arrow, that difference in mortality between the 6 ml per kilo and 12 ml per kilo groups is entirely attributable to prevention of ventilator-induced lung injury. The question is the rest of this group of patients' mortality related to the underlying disease, what brought them to the ICU, or is there something more we can do with the ventilator? And an obvious target is to increase the PEEP and recruit the lung. So we called this man, who was one of my mentors, Ray Ritz. He's actually not a doctor. He's a respiratory therapist and a respiratory physiologist. And Ray placed an esophageal balloon in the patient. And once we had the balloon in, we made these measurements, and I'll just walk you through what you're seeing. At the top is the airway pressure. In the middle is the esophageal pressure, and on the bottom is the calculated transpulmonary pressure. So we take the airway pressure, we subtract the esophageal pressure, and that gives us the transpulmonary pressure. So in this patient, the airway pressure was high. We had a set PEEP of 13 and an airway pressure, an end inspiratory pressure, a plateau pressure of 40. The esophageal pressure was very high. This patient had a huge, thick chest wall from fluid resuscitation. They had a packed abdomen pushing up on the diaphragm, which is also part of the chest wall. And the esophageal pressure measured from 20 at end expiration to 33 at end inspiration. So that gave us a calculated transpulmonary pressure of 6 at end inspiration. So in spite of a plateau pressure of 40, this patient's lung wasn't actually inflating. And at end expiration, the transpulmonary pressure calculated out negative. Now, it's not negative. There's not a vacuum in the lung. What this means is the pressure of the chest wall pushing down is higher than the pressure being applied at the airway to distend the lung. In that circumstance, the lung will collapse at end expiration. So what did we do to this patient? We increased the PEEP from 13 to 26. That increased the plateau pressure from 40 to 46. And we redid the measurements. So you can see increasing the PEEP from 13 to 26 brought this patient's transpulmonary pressure at end expiration up to only 4. So that's the equivalent of applying actually 4 of PEEP to this patient. Increasing the airway pressure, the plateau pressure to 46, increased the transpulmonary and inspiratory pressure only to 12. That is far from being a dangerous level of transpulmonary pressure at end inspiration. So applying airway pressures that I think most of the people in this room, and actually me myself before I started using this technique, would be scared of, we were only actually just barely opening this patient's lung and keeping it open. So we didn't have EIT, but you can see the chest X-ray improved substantially. And the PEEP was high, the plateau pressure was high. But if we look at this paper published recently, which evaluates driving pressure as a predictor of patients' mortality, we can go back and look at what happened to the driving pressure in this patient. So the driving pressure was initially 27, okay, a plateau pressure of 40 minus a PEEP of 13. When we increased the recruitment of the patient, we weren't over-distending the patient, we were actually recruiting him. that led to a decrease in driving pressure to 20 in spite of the much higher ventilator pressures. So this would indicate that we weren't harming this patient by increasing PEEP to this level. We were actually recruiting the lung, and the driving pressure gives us a method of evaluating that. So let me compare that patient to a second patient. We had a second post-traumatic ARDS patient. This was a 29-year-old, same general picture, chest contusion, massive intra-abdominal bleeding. And this patient was found on initial ventilator settings, CMV, tidal volume of 400, so they were getting the low tidal volume, an FiO2 of 0.9, and a PEEP of 18. So this patient, these were the measurements. Airway pressure from 18 to 30, esophageal pressures high due to the multiple injuries, and the transpulmonary pressure measuring out at negative 4.6 at end expiration. So this patient also substantially under-recruited, but this patient was enrolled in our trial, and when he randomized to the control arm. So we used the ARDSnet PEEP FiO2 table, which said that this patient should actually be on 14 of PEEP, not 18. Okay, so this patient randomized to ARDSnet PEEP FiO2 table had to have their PEEP reduced, even though the patient was very sick. So that left him at the end of that maneuver with a transpulmonary pressure of -6 at end expiration. Now, I can't tell you what happened to this patient because honestly, I don't remember. But when we go back and apply the same principle of looking at driving pressure, this patient's driving pressure increased in spite of the drop in PEEP. So we dropped the PEEP, but the driving pressure increased because we were collapsing the lung when we dropped that PEEP. So this can show you that not only can we use esophageal pressure monitoring to titrate PEEP, it will allow us to go to levels that previously we thought were dangerous because we were only looking at the respiratory system mechanics. It also may lead to patient improvement. And Laurent mentioned this study in the New England Journal where we randomized patients to either ARDSnet ventilation or to maintaining the transpulmonary pressure positive at end expiration. This study led to an improvement in some measures of the patient's mechanics. So the P to F ratio improved, the respiratory system compliance improved, the PEEP was much higher. There was an improvement in dead space, although not substantial. And this is the survival curve from this trial. It looks impressive, but it's not statistically significant. But I will say that it showed that at least we were doing no harm in implying those very large levels of PEEP. So how high do we go? This is a sample of a patient in our current study, which just closed. Actually a Canadian patient. This was a very obese man who was being ventilated with a PEEP of 17 centimeters of water. You can see that up top on the airway pressure tracing. The esophageal pressure was very high because the patient was so obese. This was a medical patient, not a surgical patient. I believe they had the flu. And the transpulmonary pressure was -11 at end expiration. So this patient randomized into the treatment arm and was managed according to the esophageal pressure. And in order to bring the transpulmonary pressure up to a almost positive number, I think they lost their nerve at the last minute, they had to go to a PEEP of 33, and this patient survived. So how many people here would put a PEEP of 33 on a patient without an esophageal balloon? Can't really see, but it looks like nobody. So this really allows you to titrate and individualize the PEEP to the patient. Another way of looking at this, so we talked about the driving pressure, but by separating the chest wall and the lung, we can calculate the actual transpulmonary driving pressure. And in data, we showed the transpulmonary driving pressure actually predicts better the elastance of the lung than does the respiratory system driving pressure. Why? Because it eliminates the influence of the chest wall. the driving pressure of the lung is actually what we're interested in. We're not interested in the, what happens to the chest wall. And it may also allow us to target tidal volume reduction. So if we look at patient number 1, where we optimize we optimize the PEEP according to esophageal pressure, we optimize the driving pressure, we also brought about a significant reduction in the transpulmonary driving pressure. And I would suggest that this is an area that we would want to look at as scientists. So Lorenzo mentioned that previous PEEP trials have been negative. And why does that happen? Why does PEEP, which seems an obvious solution to improving lung health, why does that, and by the way, proven to improve lung health in a million animal experiments, but why when we move to humans does it not seem to work? So what does a PEEP trial do? It takes patients and it randomizes them to lower and higher PEEP. Hopefully it standardizes the tidal volume, and it then looks at the outcome. But really it's taking a large heterogeneous group of patients and lumping them all together. So it's taking every patient with ARDS and treating them the same. And in that group, there are going to be non-recruitable patients. And when I increase the PEEP in a non-recruitable patient, I am going to increase the driving pressure because I'm just over-distending lung. I'm not helping that lung. In those patients, the harm from a higher PEEP is going to outweigh the benefit, and those patients are going to be injured. On the other hand, there are certainly a substantial number of patients who are going to benefit from a higher PEEP. And in those patients, the driving pressure may actually come down when I recruit the lung, when I open it up with more PEEP. And in those patients, the benefit of PEEP is going to outweigh the harm. So if I take a large trial and I lump all these patients together and I don't individualize the therapy to each patient, the end result is some are harmed, some benefit, and I have a negative trial. And I would propose to you that that's what's happened in all of the high PEEP trials, is we just haven't selected out the right patients in whom to recruit. And using esophageal pressure measurements, we are able to select those patients. We are able to select the patients who will benefit. We start our recruitment to PEEP by using a recruitment maneuver, and this demonstrates a slow flow pressure volume loop on a patient with ARDS in one of our studies. You can see we're inflating the airway pressure to 21, but this patient has a very high esophageal pressure there in green. So when we calculate the transpulmonary pressure during this pressure volume loop, we see that the transpulmonary pressure there on the bottom in blue actually only reaches 4. So I've increased the airway pressure to 21, but the actual delivered pressure to the lung is only 4. That got us to thinking, and we reanalyzed the data from the recruitment maneuvers in our EPVent study. In the blue columns, you see the airway pressures, and in the red columns, you see the transpulmonary pressures. And then we ordered them based on the transpulmonary pressure. So you can see everybody got a standardized recruitment to 40 centimeters of water for 40 seconds in this trial. We overshot on 1 or 2, but in general, 40 for 40, and that's a pretty standard recruitment maneuver. But when we calculate what the transpulmonary pressure was during that recruitment maneuver, you can see a huge variation. Okay, it goes from about 8 up until almost 30, which is definitely a dangerous distending pressure on the lung. So when we looked at the patients who had a higher transpulmonary pressure during the recruitment maneuver, there was a large increase in the elastance of the lung during and immediately after the recruitment maneuver. On the other hand, the patients who had a low transpulmonary pressure recruitment maneuver had an inadequate volume of recruitment. So really, we should be looking at this mid-zone and titrating our recruitment maneuvers also to transpulmonary pressure. Titrating them to airway pressure is easy, but actually makes no physiologic sense to the patient. And if we're looking at why previous trials have misstepped, and if you remember in the ART trial, there was a huge recruitment maneuver at the beginning. which may have well overdistended many of the lungs of those patients, causing injury. There were other issues with that trial, of course. So we're completed now this phase 2 study of using esophageal pressure measurements to set PEEP. We'll be presenting the results in a few weeks. This trial was different than the original trial. So in this trial, we continued to use for the intervention arm a protocol designed to maintain a positive transpulmonary pressure. But in the control arm, we used a high PEEP FiO2 table. So this was taken from the Canadian Oscillate trial. It titrates patients up to a much higher level of PEEP than the original ARDSnet trial. Why did we do that? Because we thought that the case had already been made that these patients benefit from higher levels of PEEP. These are moderate to severe ARDS, and we didn't feel comfortable randomizing them to lower levels. So the results of that trial will come out in a couple of weeks. I will say that the principle, however, is sound and really should be obvious to all of us. Each patient is different. You need to look at each patient at the bedside. You need to think about the mechanical ventilation of each patient. And one way to do that is using esophageal pressure measurements and calculating transpulmonary pressure measurements. I am sure that in individual patients this makes sense. I'm sure also that it makes sense for us as a community to be thinking about individualization of care and not just lumping patients, responders and non-responders together into large trials. Thank you very much.